in terms of the peak, as I said yesterday, we don't know the peak until we're looking back at it. So none of this is able to let us know if we've reached the peak or not. We need to continue to monitor and follow everything on a daily basis to see if we are flattening that curve. But really the only way to tell is in retrospect where the peak is. If we start seeing decreases, consistently decreasing number of new cases per day, everything else being equal, that usually tells us. And right now, of course, they're looking in places like Italy to see if they're in that place. But it is very challenging to know when the peak is. And the models that we presented yesterday are not about predicting the peak or predicting the future. They're about helping us plan for what we need to do and how and helping us understand the trajectory that we're on right now. What the modelers try and do is sort of triangulate. And in some places, if we look at Wuhan, for example, they estimated for every death there was X number of cases in the community. It's challenging for us to do that because, as I've mentioned, most of our deaths have been clustered in long-term care. So you can consider the cluster in long-term care as one event, for example, and determine how many people you would expect to see positive in the community given that event. The other markers we use are hospitalization. So how many people get sick versus how many people are in hospital. And again, it comes from data from other countries where they've said that, you know, X number of people have milder illness or undetectable illness, and X number of people, in relative number of people, end up in hospital or in ICU. So those are also ways of estimating how many true cases there might be out there as opposed to those who've been tested and test positive. So they've used, the modelers at BC CDC have been looking, talking to their counterparts across the country and around the world, actually. There's a lot of really good exchange of scientific information. So yes, the estimates that I presented yesterday of somewhere between 2,000 to 3,000 people being infected with this in BC are based on that type of triangulation. And it, as we said, it is, and you're correct, it's not deaths, it was numbers of true cases that might be out there, given that we can't and are not testing everybody. So that's based on some of the modeling guesses and based on what we've seen in other countries. Well, it's not unexpected, given where we are in the outbreak and the fact that we're continuing to have seeding of long-term care homes. We're continuing to do, as you say, a high volume of tests, and we're targeting the testing on people that are more likely to have the disease. So that's, you know, that's part of the trade-off. I will say, and it is absolutely the highest one-day number that we've had. But as a percentage, it still is less. So we're not seeing the percentage increase climb dramatically. It's a 92 over 884. It's a little over 10%. Yesterday was about 8%. So looking at the rate of change is something that we're also following. So it's not unexpected. It just reminds us that we are, you know, we're in the midst of this right now, and everything that we do is really important to try and keep it at that lower rate, to try and keep that inflection and try and do the best we can to prevent transmission everywhere in our communities now. So our recovery rate is quite high for a couple of reasons. One is we started getting more cases earlier on because we had these outbreaks in long-term care, and many of the people affected were young, healthy healthcare workers. So they had milder disease that didn't last as long. And yes, we did change our criteria. I think I talked about this, but nationally we've agreed that there's criteria for when people can be considered recovered after having mild disease in particular. And so for people who have not been hospitalized, who have mild disease, we are now considering them recovered when they are symptom-free, their symptoms have resolved, they no longer have a fever, and it has been 10 days since their symptoms. So that is the reason why we've been able to clear a lot of people who've been perfectly healthy for a while without having to have the 2 negative lab tests. And so that has been validated around the world. It's been because of data that we've seen, particularly from Germany, Germany, which shows that after a period of time when your symptoms resolve, you no longer shed live virus. So the test can still be positive for a period of time because the test detects the RNA of the virus. But that RNA just it may be a symptom of a virus that is no longer alive in the system, and you shed it for a period of time in your saliva, in your blood. Not in your blood, sorry, in your saliva and sometimes in your stool and other things. So we have no longer have the criteria for two negative tests 24 hours apart for people with mild illness who are not hospitalized. We still use that criteria for people who have more severe illness or who are in hospital or in ICU, or people who are immune compromised, because we know they can shed live virus for longer. So that is one of the reasons. So, and I don't know, I know Ontario is looking at as well applying those criteria.